So now we're on an elderly care ward, or it could be any ward with an older patient. And this is a scenario that gets missed more often than you'd think. An elderly patient whose mental state has suddenly changed. Is it delirium? Is it infection? Is it something else? Your SBAR needs to communicate that shift, because in older patients, confusion is often the only sign that something serious is going on. Here's the scenario. Mr. Harvey is 84 years old. He was admitted 4 days ago following a fall at home. He's been diagnosed with a fractured neck of femur and he's awaiting surgery. He's usually sharp as a tack. His daughter said he lives independently, manages all his own affairs, and has no cognitive issues. But tonight, on your shift, he's completely different. He's agitated, he's pulling at his lines, he doesn't know what day it is, and he's become incontinent of urine, which isn't normal for him. Situation. Hi, this is Dan calling from Willow Ward. I'm concerned about Mr. Harvey in bed 6. He's 84, admitted with a fractured neck of femur, and he's had an acute change in mental state over the last few hours. He was completely orientated this morning, and now he's agitated, confused, and disoriented. I'm worried this could be delirium triggered by an underlying cause. Background. He was admitted 4 days ago following a fall at home. He has a fractured neck of femur, surgery planned for tomorrow. He has hypertension, osteoarthritis, and mild chronic kidney disease. He lives alone, fully independent, no documented cognitive impairment. His current medications include ramipril, atorvastatin, and he's on regular paracetamol. This morning he was orientated to time, place, and person. Now he doesn't know where he is, thinks it's the year 2000, and he's trying to get out of bed. Assessment. His observations: temperature 37.8. That's new. It was 36.6 this morning. Heart rate 98, up from 72. Blood pressure 110/68, slightly down. Respiratory rate 22. He's had no urine output since midday, despite having a fluid challenge earlier. He's agitated, his speech is muddled, and he's pulling at his cannula. There's a small amount of erythema around his right forearm where his cannula went in. My assessment is that this is an acute delirium, most likely triggered by a developing infection, possibly a UTI or a cannula site infection, and he's becoming septic. Recommendation. I need you to review him tonight. I'd like to send a urine sample for culture, dip it now, and also do bloods, including inflammatory markers, a full blood count, and a CRP. Should I take blood cultures as well, given the temperature and heart rate? And given that he's pulling at his lines, can we review whether he needs one-to-one supervision and whether we should change that cannula site? I'm also concerned about his fluid status. Should I increase his IV fluids overnight? Now here's what makes this elderly care SBAR effective. First, you established his baseline cognition. Usually independent, no cognitive issues. That's crucial because if you don't tell the doctor what's normal for this patient, they can't appreciate how abnormal the current state is. Second, you identified it as a change. He was fine this morning. Third, you looked for the trigger: the temperature, the heart rate, the lack of urine output, the cannula site. You didn't just say he's confused and leave it there. In elderly patients, delirium is almost never just delirium. It's a symptom of something else: infection, pain, constipation, medication side effects, urinary retention. Your job in the SBAR is to paint enough of a picture that the doctor can start narrowing down the cause. And always mention the patient's normal, their baseline mental state, their usual mobility, their typical continence. Because in elderly care, the difference between normal for them and this is new is everything. Next, the A and E scenario. When things are fast and your patient is deteriorating in the resus room.